Good morning, good evening, good afternoon, everyone. Welcome to this webinar, which is focusing on WHO's policy brief on TB-associated disability. My name is Farai Mavunga. I work in the Global Tuberculosis Program, where I head the unit responsible for vulnerable populations, communities, and comorbidities, and that also oversees the work on TB-associated disability. So I'll be moderating this first part of this session, and without further ado, I will hand over to my colleague, Matsia, who will be telling us about the modalities for this meeting. Matsia also works in the Global Tuberculosis Program, where she has been actively involved in the work on TB-associated disability, and she has been instrumental to develop this policy brief that we will be also discussing today. Over to you, Matsia.
Thank you, Farai. Good morning, good afternoon, good evening to all the participants. Today's webinar is about the WHO policy brief on tuberculosis-associated disability, presenting the perspective on TB-associated disability and approaches to improving health-related quality of life during TB treatment, as well as beyond completion of the treatment. The webinar today is offers live interpretation in French, Arabic, and International Sign Language, and you can choose your preferred option by clicking on the icon at the bottom of your Zoom page saying Interpretation. This webinar is also going to be recorded. Today's webinar will have 5 sessions giving insights from civil society, insights from colleagues from non-communicable diseases on the report on health equity of persons with disabilities. We'll hear from countries and TB programs. We'll hear about researchers on the state of the art and the ongoing research on the topic. We'll present the content of the WHO policy brief on associated disability, and we'll have a panel on why to invest in TB-associated disability and addressing this issue. We would like to receive your questions in the Q&A box that you can find again in the bottom, at the bottom of your Zoom window. And we will answer your questions either live or we will get back to you after the webinar. Now I give the floor back to you, Farai, and thank you.
Okay, thank you so much, Matsia. Once again, welcome to everyone who has since joined this webinar, where we will be discussing TB-associated disability. At this point, I'm also honored to welcome in the room Dr. Teresa Kasaeva, the director of the Global Tuberculosis Program. I'm especially honored because she just arrived back from the United Nations high-level meeting on tuberculosis, and she did manage to prioritize being here for this important topic. So thank you so much, Teresa, for availing yourself for this webinar. Over to you.
So thank you very much, Farai. Dear colleagues, it's great pleasure to have you today at this special WHO webinar and introducing WHO policies on policy brief on TB-associated disability. Indeed, we just arrived from New York from the second high-level meeting on tuberculosis at the UN General Assembly. It was a very special week and a special event for all TB community, which successfully ended with the approval of the political declaration with many important and strong and concrete commitments and targets for the next 5 years. And I would like to share that there are at least 2 key points highlighting needs and problem of, in general, people with disability and disability associated with TB, and considering this as a big problem and as an essential part of care that should be strengthened. It's not a secret that due to different reasons, due to lack of funding and many other things, this part of the pathway and care was not in many cases appropriately addressed. That's why we hope that today's launch of policy brief will be meaningful contribution from WHO side, and we will work together with you, with member states, with the civil society and partners, so with the healthcare providers, of course, to provide essential support and to provide full recovery and rehabilitation to people affected with tuberculosis. And of course, disability, as addressing disability should be included in the planning, monitoring, on regular basis, and assessment evaluation of this activity should be done on regular basis. So I would like to thank you once again, and with this give floor back to my colleagues, and I hope that this webinar will be successful. We'll have fruitful discussions, we'll receive feedback from the participants, from our panelists and partners, and it will guide us how we can work together to implement this very important agenda. Thank you very much once again.
Thank you so much, Teresa. Indeed, addressing the needs of people affected by TB requires the inputs and contributions of various players and stakeholders, both within and beyond the health sector, including the academia, including civil society. So in that regard, we will be hearing from a number of speakers during this webinar who will be sharing their perspectives regarding this topic. We do have quite a number of speakers who would like to share. So I will request that I do know that we have a lot to share, but we do have limited time. So I'll request the speakers to try as much as possible to stick to the proposed or allocated time so that we get to hear from all the speakers. So without further ado, I would like to pass on the floor to Evelyn Kibuchi, who is, many of you would know, she's a longtime TB advocate with more than 10 years of experience in the field. She is also a member of the WHO Civil Society Task Force on Tuberculosis, and is currently the Chief National Coordinator of the Stop TB Partnership, Kenya. So once again, thank you so much, Evelyn. We know that you've been traveling also back from the UN high-level meeting. Would like to request you to take the floor. Over to you.
Thank you so much, Farai, for that introduction. I will jump into my perspectives, but before I do that, allow me to share the story of one person who has been affected by the result of tuberculosis treatment. Joseph is a man in his early 50s who is a TB champion in Kenya. He has suffered TB 2 times. The first time it was drug-sensitive TB, treated, cured. The second time it was extrapulmonary TB, which was drug-resistant, which affected his stomach. It was so bad that at some point he suffered stool incontinence, and he even had to use diapers. Part of his treatment included kanamycin, which left his hearing totally damaged. Joseph today is completely deaf. And I was having a conversation with him, and because he cannot hear, I requested him to write his story. Allow me just to read just in part. He says, "Now that I'm deaf and in my 4th year of deafness, with deafness, I have this noise inside my ears, noise that no one else hears. I can barely walk without a stagger. My body balance is affected. I get these memory lapses at times. There are times I can't regulate my voice, as in at times I talk too loudly or just move by my lips and no sound comes out. Though I've learned to recognize when any of these two happens and I put them right. It frustrates me because in my hearing time, I was used to audiences. Thinking of it now, I know it's not only hearing that I have lost. I've lost part of what was me. I lost my job as a HIV service provider. I lost my friends too because my social life changed. I had to isolate myself, and others isolated me due to incompatibility issues. Working with a weekend body is a hassle, and I have to replan and strategize. This isn't easy, but this is a new me, and I have to get a way of life, a new way of life to be lived. The question is how. So that's what Joseph writes about his current status, living with deafness that has resulted from TB, MDR TB treatments. Having shared this, I want now to give my perspectives and say that first, the world really needs to apologize to these people who have been affected by TB because of me moving too slow in investing in research and development for proper treatment with less adverse, side effects. Secondly, also moving too slow in investing in prevention so that a disease that is preventable, is curable, and is treatable does not lead to such devastating effects. Living with TB is bad enough. Living with disabilities that have resulted from a curable, treatable disease is unfathomable. So from my perspective, what I would say is, one, now that it has happened, we need to see how we help these people to live, live the most comfortable life and be most productive with the new state found themselves in. And how do we do that? First, countries should do a census to establish the numbers of the such people that they have in their country so that it can inform their interventions, knowing the magnitude of the problem in their countries. Secondly, we need to ensure that these people are involved in all decision-making processes. They are the people who knows where the shoe hurts most. We also need to ensure that they access social protection at the country level, avail commodities that ease their pain, for example, hearing aids, oxygen concentrators, any commodities that will make their life easy, and this should be availed for free. We also need to develop policies that address their needs. And I'm happy that WHO has come up with this policy brief that should be the beginning point of seeing how we address this problem. And finally, that now that Farah, you have mentioned that I'm coming from the United Nations high-level meeting, the declaration that has just been launched in chapter 52, it has made reference to persons living with disability. And I think what needs to be done now is to move from the paper and move to action and implement the provisions that have been given, or the targets that have been given in the declaration regarding persons with disability. I will stop there and listen from other people. Thank you so much.
Okay, great. Thank you so much, Evelyn. And we also know that you are still in transit, traveling back from the high-level meeting, and we do acknowledge that you were not able to put your camera on for that reason. But thank you so much. Also, very concrete proposals on what can be done to address or to begin to address, where it hasn't started yet, the needs of people with TB-associated disabilities. So thank you so much, Evelyn. Now we move on. We would like to hear from someone who has experienced TB firsthand. That speaker will be Nandita Venkatesan. She is a TB advocate, but who has also survived TB and was also served in the past as a member of the WHO Civil Society Task Force on TB. Over to you, Nandita.
So much for having me. It's really good to see everyone here. Quite some familiar faces around here for me. Thank you for hosting this very important and a very pertinent topic around TB and disability that is not discussed as often as it should be. So, like the host said, that I do have a first-hand experience of dealing with this, wherein I ended up having TB twice in my life at a young age during my teens and my early 20s. And in the process of getting cured for this disease, I ended up losing my hearing completely in literally the blink of an eye. I keep saying this very often because that's exactly what it had happened because of the kanamycin injections that were administered to me. Recently, we fought. Uh, Recently, we fought a patent opposition on bedaquiline in India, and me and another TB survivor from South Africa, Fumeza, we were named in the Time 100 Emerging Leaders globally by the Time magazine recently for our work in improving access to bedaquiline drug, a drug that is seen as a very critical part of the multi-drug resistant TB regime and also seen as an alternative to prevent these kind of hearing loss that is induced by TB. And here is where I would like to point out a fundamental point here is that the way I see it is disability can be of two types. One is something that, let's say, you acquire at birth, which is what happens to many people. Say you undergo an accident, you end up losing your hearing at birth. Hearing loss is something that primarily affects people when they are very young. So there are some of these things maybe that is not avoidable. But there is another form of disability that I suffered, which could have been completely avoided, I feel, had we had access to better medicines, had we had access to better drugs, had we had access to better diagnostics. And this is where I think that when TB falls in the second category that I spoke about, when it happens due to when it is something that could have been avoided, I feel that this to me indicates a failure on the part of science, on the part of science to catch up and see to it that these kind of disabilities still exist. This when it happens in the former, let's say, when I would hear about disability before I suffered it myself, I would often hear that hearing loss, for example, would happen to, say, mothers, children who are born to, say, pregnant mothers who have undergone some problems during pregnancy or things like that. These are something that you don't know whether it can be avoided or whether it cannot. What happened to me was something that I realized as I started my advocacy journey was something that could have been totally avoided had we had the science catch up with TB, had we had advanced science catch up with TB as it has been doing with so many other infectious diseases that has happened. And it was in the quest for that we embarked on this journey to see to it that we do our bit as survivors to speak at every forum possible to bring to policymakers, to make policymakers aware that that disability is something that is a very real problem for TB patients, and that it is a problem that needs to be addressed head on, and there's no time to waste on that front. Thankfully, since then, at least some work by scientists, work by TB survivors and advocates like us, holding seminars like these have helped at least to bring forward these issues. Because when I had started my advocacy journey, I remember, say around 6 years back, I remember most people would not even be aware about this. I would get blank stares when I would tell people that I lost my hearing because of TB. Most people would find it very incredulous. They would not believe this, that a medicine has actually caused my hearing loss, and that my hearing loss happened right in the middle of my life, that I did not lose my hearing at birth. So we have come some way from there. but it is very important that we sustain the momentum on this. And it is also important that apart from say pushing for access to better medicines and more importantly access to better diagnostics, we also need to see to it, as Evelyn said, that that people who have already suffered hearing loss, unfortunately, adequate information should be available to them on where they can seek post TB and post disability care in terms of accessing hearing aids, in terms of accessing cochlear implants, and also say if a medicine causes say blindness, for example linezolid often causes problems with eyesight. It is important that doctors inform patients beforehand of these side effects, and in case it happens, the patient does end up suffering the side effect, immediate point of care should be available to that patient, and that patient should be told as to where they can go and find out. So I think these are some of the critical aspects that need to be looked into, and I hope that this brief covers a lot of these going forward. Thank you.
Okay, thank you so much, Nandita, for that very clear and powerful testimony. And I also would like to acknowledge and congratulate Nandita. She was recently named in the top 100 emerging leaders globally in Time Magazine's Time 100 Next list for her work in TB advocacy. So congratulations, Nandita, for that. So we'll shift slightly in terms of focus to now hear from the WHO non-communicable disease department, where my colleague Kaloyan Kamenov works as a technical officer, and he is responsible for the development of normative documents and supporting member states in capacity building on disability inclusion in the health sector. Over to you, Kaloyan.
Thank you very much, Farai, and good morning and good afternoon to all the participants in this webinar. It's a great pleasure for me to be here on behalf of the WHO Disability Program. And firstly, I would like to congratulate my colleagues in the TB program for their leadership and for publishing such an important document that will surely raise awareness on this issue that we are speaking about today, and also lead and advance disability inclusion in the health sector and in TB programming in general. I will present another document that WHO published about a year ago. It is the Global Report on Health Equity for Persons with Disabilities, that is very much related in its content and also messaging to the policy brief that is the focus of this webinar today. The Global Report has two main functions. The first one is to present the available evidence on the health inequities that persons with disabilities experience globally, and also the contributing factors that lead to these inequities. And the second function is to provide recommendations for governments and also other health sector partners on how to advance health equity for persons with disabilities. The report estimates that currently about 1.3 billion people globally have significant disability. And this is a substantial percentage, as you can see, a substantial number. We talk about 1 in 6 of us. And the report also shows that this number has increased in the past decades and is also projected to increase in the future. And when we talk about 1.3 billion people, of course, there are people in this number that have a variety of underlying health conditions and impairments, including TB. We show in the report that the number of people who have disability and associated with respiratory infections and TB has increased substantially in the past decade, from a little more than 10 million in 2010 to almost 60 million people in 2021. And as you can see, this is a really a huge increase in the number of people. And we know that people with TB-associated disability, but also with other underlying health conditions, persons with disabilities in general experience a range of health inequities. Many of them die up to 20 years earlier compared to persons without disabilities. They have a double risk of developing secondary conditions like depression, diabetes, stroke, but also communicable diseases such as TB. And they also very often experience more limitations in everyday functioning compared to their peers without disabilities. But one thing that is important to highlight here is that these inequities, the premature mortality, the increased morbidity, they are not because of the underlying health conditions. They actually are triggered and driven by unjust and unfair factors that are largely avoidable. And these factors lay within the health system, but they can also be at societal level. So when we talk about factors in the health system, we can look at poor access to healthcare, physical inaccessibility of hospitals and health facilities, communication barriers, or very often negative attitudes by health professionals towards persons with disabilities. But these factors go beyond the health system at societal level, like societal stigma and discrimination, higher rates of poverty, poorer living conditions, and many more factors that we look into detail in this report. And if we look more closely, for example, at TB programming and TB prevention strategies, we can see that very often they're not inclusive for persons with disabilities and they do not reach this population. This may be because public health interventions are not accessible, or because the public health interventions may be out of reach. Imagine if a person with disability needs to go to a health facility to receive an intervention, and they need to use transportation, but this transportation is not accessible or affordable. They simply cannot go. And of course, this can increase the chance and the risk of premature mortality or increased morbidity in these people. Now, having all this evidence in mind, the report provides a list of recommended actions for governments and also for other key actors in the health sector and also in the disability field. But before I go into the recommendations, one thing that the report also does is to demonstrate that investing in disability inclusion is the right thing to do, because the health sector ultimately has a responsibility to address health inequities. This responsibility lays down in international laws and conventions like the Convention on the Rights of Persons with Disabilities, but also in national strategies, laws, and policies. And we know that we will only achieve the global health priorities like SDG 3 on good health and well-being, or universal health coverage, or protection for the population in health emergencies, if health equity for persons with disabilities is improved and advanced. But investing in disability inclusion is not just the right thing to do, it's also a smart thing to do. And the report shows that if standard interventions like immunization, prevention strategies, or management strategies are delivered in an accessible and disability inclusive manner, they are still highly cost effective. Now, as I mentioned, the report provides a list of 40 recommended actions. And we know, of course, that there is no country in the world that will be able to implement at once all these 40 actions because of lack of resources, different contexts, and priorities. But what we really advocate for in the report is that whatever action is taken by a country, 3 key principles need to be integrated. Firstly, health equity for persons with disabilities need to be at the center of any health sector action. For example, if a country is investing in training their workforce, a training on disability inclusion should also be included. Or if a country is revising their financing mechanisms, then health equity needs to be at the center so that those that are most marginalized and left behind are put first in those mechanisms. The second principle is that persons with disabilities and their representative organizations need to be engaged in any decision-making processes in the health sector. And lastly, that whatever action is taken, it needs to be monitored and evaluated. so that governments know the extent to which this action leads to health equity, what works, what doesn't work, what can be improved in the future. I will stop here and put the link to the report in the chat so that everyone can have access to it. And I will also leave my email address. If you have any questions after this webinar, please feel free to reach out and I will be happy to answer. So thank you very much for the opportunity to present again. And back to you, Farai. Thank you.
Okay, thank you so much, Kaloyan, and also thank you for the very concrete actions that countries could take towards disability inclusion. And I think, as you rightly said, it's not just the right thing to do, it is the smart thing to do. So thank you so much for taking time to share the summary of that report. We'll now move on to hearing from two countries where they have initiated work to address TB-associated disabilities. We'll be hearing from Tanzania and from Malawi. So first, I'll now invite the speakers from Tanzania. There will be Riziki Kisonga, who is the National TB Program Manager for Tanzania, as well as Nyanda Tinginya, who is with the National Institute of Medical Research, Tanzania, who's also working with the TB program in scaling up research efforts related to TB-associated disability. So over to you, Riziki. Thank you so much for making time for this webinar.
Yeah, thank you so much, Dr. Farai. All protocol observed. As you have highlighted, I'll be presenting this with Dr. Nyanda. And really, indeed, I want to recognize the effort which has been put with a civil society organization, our academias and research institutions in making sure that our country really start addressing this through several demonstrations. Next slide. Next slide, Nyanda. So we understand that despite of this good and best treatment success we are seeing nowadays globally, yet we have something to do. We have something which is remaining at the end of TB care, as Evelyn has shared. In Tanzania, through different demonstrations, we have noted that those patients whom we term them, they are cured, still have remains with TB symptoms. We can call it TB symptoms. But looking at the demonstration which was done by NTLP and WHO in one of the regions in Tanzania, we saw that actually when you involve the community, you improve the referral mechanism of those patients who have what we call chronic lung disease symptoms to health facility. But again, creating awareness to our healthcare workers really makes a great effort to make sure that they really recognize these patients once they are visiting the health facility. But again, from the TB secular study, which ended 2 years back, again, there are evidence that 30% of our participants, actually, they remain with chronic cough, as I have highlighted above, but a little bit, more than 60%, they still have some lung pathologies when you do the chest X-ray and the other images. Next slide. Oh, sorry. And we understand that these lung pathologies have mixed lung impairments. Dr. Nyanda?
Yes, thank you, Riziki. And with this understanding, knowing the burden that we are having some comorbidities in the lungs and during treatment and after treatment, the TB program and other players, including civil societies like Mkuta and the TB secular network in Tanzania, we started advocacy on the matter. So in September, we hosted a dissemination meeting of the TB sequela findings in Tanzania that was attended by our partners in Munich and Orem, together with the Ministry of Health, physician, pulmonologist, implementing partners. And later on in November, thanks to WHO, with Ernesto and myself, we were invited to present on our findings, and also a global fund led by Dr. Eliud Wandwalo. And later on, in March this year, we convened to update our NTLP operational research to factor in post-TB lung disease. Thankfully to the second International Post-TB Symposium in Stellenbosch, where we had an opportunity to share the advocacy on post-TB lung disease in the larger forum. And later on, as we appreciate SOMAT Global Fund convened in Arusha a meeting of over 11 countries from Africa and India, where permanent secretaries met. And also one of the Arusha Declaration commitment was about assessing and implementing post-TB lung disease as a continuum of quality care. And we appreciate Global Fund for appreciating. So this has been an advocacy journey in this regard on post-TB related diseases.
So what Tanzania has done so far in making sure that the PTLD now comes into pictures. Next slide.
I'm trying to trace it in.
Yeah. So while we are trying to make sure that the slide comes in, what Tanzania has done so far is that we have started integrating PTLD in the national TB policies and the strategy. And thanks to the midterm review, which was done early this year, which noted that PTLD is something which needs to be addressed. And we have reviewed the national strategic plan and put in addendum the interventions which are really explicitly talks about the PTLD. We have started piloting the PTLD care in 2 districts in this Tanzania. And thanks that through this Global Fund Cycle 6, we have indeed incorporated the PTLD interventions in the grant submission. What we have noted that training our community health workers have been the pillar to make sure that they start being part of the care. What you see in the picture is that these are a group of patients who were cured of TB, but they remained with post-TB disabilities, and now they are doing a pulmonary rehabilitation at the community. So this being part of the care, which we are trying to demonstrate so that it can be documented. Nyanda?
It's talking.
Yeah. While Nyanda is making sure that the slide moves. So what have we seen? What have we seen that if we want to improve the PTLD care in health system, what is supposed to be done? One is that making sure that training our healthcare workers and clinicians are the pivotal, but establishing the referral pathway of our patients from the community to the health centers is again is vital. But recognizing that we need to really advocate on the risk factors, social support, social protections, and the pulmonary rehabilitation care. The issue is that the findings which were from the Impala taught that really, indeed, addressing the chronic lung conditions or diseases, it improves the quality of care to our patients. So, Nyanda?
Yes, and in this regard also, we are cognizant of making awareness and also building capacity to our healthcare workers so that they can have skills to prevent and detect and manage as well as come up with research questions, because they still unknown that we need to factor in so that we can integrate into practice. However, we are aware that our patients need to be aware and understand also some of these risk factors for strategies to be well appreciated across. And in this regard, is to finalize our presentation. We understand, despite that we have some information already in Tanzania and that we are advocates and also some form of integration at the preliminary stage, we need country-owned data, especially including that will map the existing research as well as routine. Dr. Kisonga, the program manager, has highlighted we are going to have demonstration side. This also will feed into the information for us to continue updating our guidelines. Also, we are aware of WHO shared the protocol to do operational research, so we look forward to make use of this and also lesson learned. So the TB sequela funding in the next 5 years, we'll also look at the association between PTLD and long-term morbidity and mortality. And we hope that this will further contribute to the information to the country. However, key questions remain with us. You know, integrations comes with costs. And we are wondering whether such interventions within, during and after TB disease will be supported through the same mechanism as for the TB disease. So thank you so much for listening.
Okay, thank you so much, Doctors Kisonga and Nyanda, for that excellent presentation and sharing your experiences. I think you have a lot to share, and in this limited time, you have managed to cover aspects of determining the magnitude of the problem of TB-associated disability, particularly focusing on lung-related disorders associated with TB, but also issues of advocacy, research, engaging and involving stakeholders, incorporating these interventions in strategic plans, resource mobilization, including from the Global Fund, the role of engaging communities. So I think there are various aspects that you've covered, including also capacity building, the need for referral networks, and addressing all the other issues around the person with TB, including social protection and risk factors. So I think that's a lot that you've packed into this presentation, which I think is very relevant for this discussion today. So thank you so much for that presentation. So we'll now move on to Malawi, where we will hear also from their experiences addressing TB-associated disability. We are supposed to have, again, a representative from the National TB Program, Tisungane Mwenyenkulu, and from LHL International Tuberculosis Foundation, Mona Drage, who is also working with the National TB Program in addressing TB-associated disability. So Mona, over to you.
I think maybe we give the floor to the NTP first, if they are ready. Or I should go ahead with my presentation. We haven't done a joint one, unfortunately.
Okay, no, great. Thank you so much, Mona. Tisungane, just checking if you are connected.
Okay.
If not, then we'll see if we can get Tisungane a bit later, but you can go ahead, Mona.
Thank you. So, thank you to WHO for developing this policy. It's very timely and should be an important tool in the future, the work ahead of us. And I'm also very grateful to be able to share our experience from the ground, highlighting why this focus is so important. What should and could be done, and also what works, because the work has started. And it's very nice to have been speaking after the NTP manager from Tanzania, to have listened to their perspective. So LHL International and our partners, we work to reduce the burden of TB. And the burden of TB is so much more than the epidemiological part. We all know that, but we have various success in addressing it. And the consequences of the inability to address these various burdens, we can see in the 155 million TB survivors. This is the estimate of how many people who live having survived TB today. Many of these continue to suffer from TB-associated disabilities long after they are declared cured. And these are disabilities caused by TB, and we have to try and prevent this as much as possible by getting better at treating the whole person and not only the bacteria. So we've had a project now looking mainly at life after TB. Part of it has been in Tanzania and a major part also in Malawi. So I'll talk mostly about Malawi. We've tried to gather data to document the plight of TB survivors and also try to address some of their challenges. So what did we find? In Malawi, we have data of more than 1,700 TB survivors, and 70% of them experienced health problems. We look at what symptoms and how it affected their daily life. It was mainly lungs, but also pain, neurological challenges, and fatigue. In this data set, we didn't find many people reporting mental health challenges, but we believe this is a weakness of the tool. If you want to talk about mental health, you need to go a bit more in depth and do a better job. Like we did in Tanzania, the lung rehabilitation program there, we had a psychologist do a mental health screening for all the participants, and they found 34% of the lung rehab participants having mental health challenges. So who are these people? We know TB is a disease of the poverty, but I think still the findings we found among the 1,700 TB survivors were striking and very disheartening. In this graph, it's kwacha, but I will translate it into dollars. We found that 70% lived in extreme poverty before being diagnosed with TB, so under $1 a day. This moved up to 86% after having been cured of TB. So this is a very poor population. So I just want to brag a bit about our achievements so far. In this project, we've given care and support to 2,000 people with TB-associated disabilities. We've had 600 participants in lung rehabilitation, and we've done a lot of capacity building on TB-associated disabilities and also inclusive health communication. We've developed tools that can be used and freely used, also in e-learning and inclusive health communication. And also developed a post-TB disability curricula that will now be taught to public health students in the University of Livingstone, Malawi. So, from our data, we saw that treatment delay was common. 51% reported a delay more than 6 weeks, and 28% more than 4 months. And if you look at the pie chart, you can see the reasons for the delay, and that health system delay is massive, or substantial at least. It's the main part. So here we have a lot of work to do. We also looked at nutrition, and among the group in Tanzania, we saw severe acute malnutrition among 6% and moderate among 24%. And in Malawi, 18% had moderate acute malnutrition. Yeah. So what can we do that works? We need to find patients early. That's one thing. We also need to look at nutrition support during treatment. I mean, there's a reason why tuberculosis is called consumption. The treatment itself is hard on the body, and we should start looking at food as part of the medicine, not just an add-on. but we should also do community-led lung rehabilitation. We've been testing this out, and Bruce Matawera from Malawi will speak more about it later. But I just want to make sure to say that this works. It's cheap, it can be done in the community, it can be done with the former TB survivors leading it. And it's not easy to, it works, it's simple, but it needs to be organized. Because we can't really ask people to just exercise on their own. These people have been very sick. It's very scary and painful in the beginning. If you are coughing, producing phlegm, you're having fatigue, all of a sudden you're supposed to start exercising. And also the social support and the motivational part of it is also very important. So what can NTPs do right now? Of course, first of all, go and read this policy brief from WHO and start implementing that. But like Dr. Kisonga also talked about, involve CSOs and TB survivors. Because that's how we can ensure that TB treatment is truly holistic and people-centered. We also need to prioritize management of symptoms and adverse events during treatment. We need to do screening for mental health as a routine, and screening for post-TB lung disease during treatment also. We need to include the period after treatment as part of the TB care cascade, and we need to look at people with PTLD as a risk group for recurrent TB. In Tanzania, among the people who did lung rehab, they found 24% of recurrent TB. So our suggested way forward, I think we have found a model on how to do low-cost community-based lung rehabilitation, and that can be replicated in other places. But we also need to learn more about the long-term effect of lung rehabilitation. And we need to look at, can we do it during treatment? Also the effect of nutrition during treatment. We need to develop a minimum package for post-TB care. And we need to have a greater focus on mental health. That was all from me. Thank you for allowing me to speak.
Okay, great. Thank you so much, Mona, for that. Again, very comprehensive overview on TB-associated disability and some of the interventions that you have been piloting in Malawi. I'm just checking if Tisungan has joined. Okay, it looks like they might not be able to join. So thank you so much, Mona. I think, you covered the broad spectrum of the aspects that are related to TB-associated disability, both in terms of, the psycho or the socioeconomic factors that are, linked to this problem, but also in terms of what you have piloted or what you have implemented, including various capacity building initiatives. And also, I think there's a lot of talk these days of e-learning, but the important points also that you highlighted pertain to the role of the communities and affected people, and ensuring that our services indeed are holistic beyond just getting rid of the disease, but to address all the needs of the affected person. So thank you so much to both countries. At this point, I would like to pass to my colleague, Ernesto Jaramillo, who works in the Global Tuberculosis Program with us as well. Ernesto is leading the work on ethics, equity, human rights, disability, as well as social protection. He is indeed passionate about TB-associated disability and has been a strong advocate of ensuring that we mainstream this topic in our TB programming and as part of comprehensive services for people with TB. So Ernesto will be moderating the second half of this webinar. Over to you, Ernesto.
Thank you, Farai, and good morning to all of you, and good afternoon those of you who are joining us now. Now we are going to move towards a small panel where some leading researchers will be sharing with us what is the ongoing situation when it comes to evidence. And we have invited a global leader in tuberculosis, but also a very well-known Professor Chakaya, who is passionate as well on TB-associated disability, particularly with pulmonary comorbidities. Jeremiah Chakaya is now currently professor at the Liverpool School of Tropical Medicine in the UK, but he has been chair of the staff of WHO and former NTP manager in his country in Kenya. And in the panel, we are going to have probably the people who are really doing cutting edge research at the moment in the field. Denise Evans from Witwatersrand University in South Africa will be presenting briefly the outcome of a scoping review that was commissioned by WHO to determine the existing evidence and the grounds for moving forward with the policy and some guidelines. This will be followed with Brian Allwood, who is a pulmonologist at the University of Stellenbosch and absolutely a leading force, particularly on the post-TB disease component of the TB-associated disability. Bruce Matewere is the chair of the Paradiso TB Patient Trust in Malawi, who is an NGO, a civil society group that jointly with Mona Draghe has been pioneering some of the interventions that she has just shared in the previous intervention. And last but not least, we have Ronnie Zakaria, who has been a researcher in TB for quite many years, particularly when he was in Doctors Without Borders in MSF, and now is in the WHO Tropical Disease Research Program, and is currently leading with Tony Harris in the Union and with support of USAID some field work precisely with countries that are realizing that it's not enough to cure people with TB, but to ensure that lives are enriched because people are left without impairment and sequela. I would like to invite then Chakaya to be the moderator of this panel and invite this distinguished list of speakers to share with us the findings and their perspectives on the research that they are conducting. Over to you, Chakaya.
Thank you very much, Ernesto. Good morning, good afternoon, good evening, everyone. First, I want to say a big thank you to colleagues at WHO for the opportunity to moderate at this very important session on post-TB disability. We do know a lot for sure, but again, we also do not know a lot. There's a lot of things that we do not know. And we are going to hear today what the state of knowledge is about post-TB disability. Who gets what problem? Can we prevent it? How should we be able to pick it up? How should we record and report our efforts? How will we know that we are making a difference? What outcomes are important to us and to our patients, and so on and so forth. Without wasting too much time, I will ask Denise to make her presentation. You've already heard where Denise works. I don't need to repeat that presentation. You have the floor, Denise.
Thank you so much, and thank you for that introduction, and a warm welcome. Good morning, good afternoon, and good evening to all. And it's with my great privilege today to present on behalf of my investigators, collaborators, and consultants a summary of results from a scoping review that we did for the WHO on the interventions to address TB-associated respiratory disability. So there is a growing body of literature that describes a significant burden of TB-associated disability. And in this review, that was a systematic review that was published in 2021, they highlighted the most common types of disability. And this was a systematic review of more than 200,000 patients from over 50 countries and 130 studies. And you can see in the figure on the right, they highlighted the most common types of disabilities. And for the purposes of our scoping review, we focused on respiratory impairment. So what we do know is that TB-associated disability is associated with an increased risk of morbidity and mortality both during and after TB treatment. Individuals have poorer TB treatment outcomes, a reduced health-related quality of life, and increased cost to both the individual, their households, and the broader community. So there have been calls from TB-affected communities and national TB programs to address TB-associated disability with guidelines as well as appropriate TB services. So the question that we addressed in the scoping review was, is there sufficient evidence for WHO to produce standardized guidelines to prevent, diagnose, and manage TB-associated disability? So now a large body of data that suggests up to half of patients with pulmonary TB have abnormal imaging or spirometry at TB treatment completion. Many of them, including secondary infections, exacerbation, as well as secondary cardiac disease. This can also translate into chronic respiratory symptoms, decreased exercise capacity, and reduced quality of life. And we also see ongoing reports of stigma, disruption in daily activity, loss of income and employment. And this ultimately leads to disability, which is, as the UN Convention defines, is the prevention of full and effective participation in society on an equal basis with others. So in summary, the literature really describes both the nature and the impact of disability. But what we don't see is many intervention studies describing how to prevent or manage these disabilities. So in the scoping review, the first thing that we did was to really understand the key interventions. And here we obtained expert opinion. And we looked at and we grouped the different interventions, the most common interventions, into these 5 categories. So you can see for during TB treatment, we have prevention of lung damage, then screening of lung damage at treatment completion. We then have, and this is after treatment completion, supporting recovery and providing ongoing care. And then for some individuals, also preventing and managing exacerbations, and for recurrent TB disease, appropriate diagnosis. And so what we did based on the expert opinion that we received, we then there are 6 interventions that we identified. So you can see these are highlighted in orange. We have smoking and nutrition, physiotherapy and rehabilitation, as well as psychosocial support. Interventions reported by the expert opinion, but also the interventions that we thought could be delivered in a decentralized manner in the public care. So here is a summary of the results from the 6 intervention groups. So we used 10 databases from the year 2000 onwards. So we searched for TB together with these 6 interventions. And we also looked at impairment or disability at or after TB treatment completion. So overall, we screened over 12,000 abstracts and titles. From that, 329 met our eligibility criteria. And then finally, 24 full papers or full texts were used in the data extraction. And just to highlight here, the most common intervention that we identified was the physiotherapy and pulmonary rehabilitation, 8 out of the 24 full papers. So just in summary, what did we find? So a limited number of intervention studies reported on post-TB outcomes. As I mentioned before, the focus really of many of the studies was on pathology, describing the pathology and the impairment, rather than the management or the prevention of disability. Very little work on qualitative or mixed methods work. We had little data to inform implementation, so lack of feasibility and cost effectiveness, also limited data for children and adolescents. What we did find is that the studies, from the 24 studies that we extracted data, these studies reported diverse outcomes and tools across the different studies, and different tools to measure respiratory symptoms, lung function, capacity and quality of life. And this made it very, quite difficult for us to compare findings across the studies. Findings were also mixed, and were often very specific considerations and limitations for the different studies. For example, a small sample size, a lack of quality control, or no control group included. Also, limited data on the long-term impact of interventions. So in summary, overall, we had a lack of high-quality studies of interventions to prevent or manage respiratory impairment or disability after TB treatment completion. Our study did have some limitations, but just to highlight that very limited data to make any recommendations to develop guidelines for integrated TB respiratory care. There are considerable gaps in our understanding of which interventions, in whom, and when along the TB care cascade these interventions should be implemented. And lastly, we just wanted to encourage more data collection, including with the inclusion of the disability measures of key outcomes and standardized outcomes across studies, and key outcomes in intervention trials with longer term follow-up to describe these long-term outcomes. And with that, I'll end there. Thank you for your attention.
Thank you very much, Dennis. And again, wonderful presentation there on what we have picked up from the literature so far. I don't need to introduce Brian. I think Brian has been a champion of post-TB, disability and lung disease for a long time. He's been pushing all of us to do something about this issue. And yeah, so let's hear you, Brian.
Hi, good day, everybody. Thank you very much for the introduction. I am humbled to be part of this symposium, and just thank everybody who's gone before for these wonderful presentations, who just meant so much to all of us. In the interest of time, I'm going to confine my talk really to the biological model of post-TB lung disease. I fully acknowledge that there are many other aspects of post-TB disease in life, but I believe that the principles I'm going to share are applicable across the board. So I'm going to talk about the research priorities. For those that don't know me, I'm Brian Allwood. I work as a clinician pulmonologist at Cape Town and Stellenbosch University. So let's just take a moment and look at these x-rays. These are all x-rays of TB survivors. Every one of these x-rays is a person who has hopes, dreams, families, and a future. But there are 155 million other survivors of tuberculosis, many of them who will have x-rays and physiology that's similar to this. And I believe that we spent the last 2 decades measuring and looking at the pathologies of TB, but now it's time to move towards treatment and prevention of this disease and lung disease. What do I mean? When I talk about treatment and prevention, I talk about primary, secondary, and tertiary prevention, or treatment, so to speak. So primary prevention is obviously prevention of TB itself, and this is the holy grail and something that we as a community are really working very hard to try and affect. But even if we cure TB tomorrow, which is highly unlikely, we still got to remember there are 155 million people who have to live the rest of their lives with this stigmata of tuberculosis. So probably more realistic is secondary prevention. And the last 2 decades have been quite exciting in the TB world, with new drugs and new regimens coming along. But the reality is that all of these trials have focused only on microbiological outcomes. And we really believe that this is no longer defendable or acceptable. And we are calling for all future and current TB drug and regimen trials to include at least lung outcomes. It's a little bit like having a stroke intervention trial where all you're concerned about is if the patient is alive or dead at the end of the trial, and not actually looking at the residual level of function after your stroke intervention. So we, as the steering committee for the second post-TB symposium, have recently published this paper in the ERJ. which you can read if you want, calling for the inclusion of lung outcomes. But also very important is, are there things that we can or should be doing during TB treatment? Is there therapy, for example, that might improve outcomes? And I think this is really an important concept, host-directed therapies, for want of a better word. But in order to do that, we need to really understand the pathophysiology and the drivers of the disease, what is causing and perpetuating this lung damage. After the TB episode, we need to look at tertiary prevention and treatment. And as many of the speakers have said, we are calling for a new baseline assessment. So what is the new normal for that individual patient? Exactly what this includes is a bit controversial and quite contextual, but should probably include some measure of radiology and spirometry where it's available, and clinical and psychosocial review, and probably some measure of a performance assessment. Next, we need to try and determine, in collaboration with our patients and advocacy groups, what are the most important outcomes for our TB survivors. We don't know exactly what all of these are, but Denise alluded to some of them, and these are some that I'd like to put on the table that we need to look at. We need to reduce mortality. We know, as Denise pointed out, that mortality is increased in TB survivors 3 to 4-fold. There are the compatriots. We need to prevent TB relapses, as both Mona and Denise mentioned before, because this is a low-hanging fruit, and recurrent TB obviously will cause more morbidity and shorten life expectancy. We need to reduce the negative outcomes. We need to look at exacerbations and hemoptysis, amongst others, which are very distressing. And then we also need to see what is clinically meaningful for our patients. How do we decrease their symptoms, and how do we slow progression? So another very, very important concept is that we need to validate our outcome measures. We don't have well-validated outcome measurements in TB-associated disability, and we need to, if we're going to design interventions, we need to validate our outcome measures. And that's a really important foundational principle. And again, we need to research what is driving these mechanisms of poor outcomes. Are there confounders we're not looking at? Very difficult to know. We need to put a lot of time and effort into that and understanding that. And then finally, with all this in mind, we need to design interventions and programs to improve outcomes for our post-TB survivors. And this is, again, very contextual, and you've heard about pulmonary rehabilitation, and it's too detailed to go into now, but the broad principle is that we need to design things that have clinically meaningful and clinically measurable and cost-effective outcomes for post-TB interventions. So it's a very short talk and a short summary, and I've just captured the broad principles, but in summary, we need to include lung outcomes in all our TB drug trials. We need to develop interventions that can modify and improve outcomes. We need to understand the pathophysiology of the disease. After TB, we need to define a new baseline assessment, which is the new normal from where we can work for. And then we need to look at patient-centered outcomes to validate these measures of outcomes and to do research into the poor outcomes, and then design appropriate interventions and programs. And I just want to highlight that these things don't have to be done sequentially, but they can all be done concurrently, and we can start all of them at the same time. So with that, I'm going to hand it back to you. Thanks, Chikaya, for the opportunity to speak at this forum. And again, just very humbled by all the presentations that have gone before and so much good work that's going on in the field. And thanks very much.
Thank you very much, Brian, for highlighting extremely important issues that I think are critical for us to consider as we move forward in designing programs for the prevention, care, and treatment of people who have suffered an episode of TB. Is Bruce online, and can we move to you, Bruce?
Thank you so much.
You have the floor, Bruce.
Hello. Hi, everyone. Good morning, good afternoon to everyone. My name is Bruce, and I work for a patient organization called Paradiso TB Patients Trust. Today, I'll present to you on results of a project we implemented called Filling the Gap, Finding and Addressing Post-TB Disability. I'll share the Malawi experience. As a patient organization, Paradiso was established, and Our work is to identify, refer symptomatics, and support TB patients until they're cured throughout the course of treatment. And to do this, we established TB clubs composed of TB survivors, and currently we have about 1,091 TB survivors across the country. It was not until 2019 that we added the care, post-TB disabilities care, through this project that we implemented. I'll just highlight a few of the achievements that we've done in terms of identifying cases and putting them on treatment and supporting them throughout treatment. We've been able to reach to 526,000 people with TB information, screened 82,000 of these, and out of the 82,000 screened, 23,000 symptomatics were identified, of which 1,420 people were diagnosed with TB. We're also able to support 140 MDR patients with nutrition throughout the course of treatment. But with all this work, we started learning, because we work with TB survivors and patients, that they were still facing some disabilities and impairments, even after being cured of treatment. It was because of that that we embarked on this project, post-TB disability project with LHLI, in partnership with LHLI International. So in this presentation, regardless of the work that we do, we're going to concentrate on the post-TB project, but mostly on the lung rehabilitation program to see the results and its effects, and then make recommendations. What is the low-cost community lung rehabilitation program? This is a 12-week program aimed at managing patients with post-TB lung disease. We developed this program together with 3 physiotherapists in the country. We use aerobic exercises as an approach. Participants are assessed at baseline and at 12 weeks. In the pilot phase, we also assessed at 6 weeks to see which one will give us optimum results. Exercises are done twice a week for the duration of the 12 weeks. We piloted the program in 3 health centers, and due to the excellent results, we scaled it up to 6 health centers up to June 2023. But up until now, with funding from LHLI on another project, we've been able to sustain a few of the sites doing the lung rehabilitation program sessions. In order to do this, because we're doing the low-cost lung rehabilitation program at primary level where we don't have physiotherapists, we task shifted and trained 55 healthcare workers and volunteers to do the medical assessment and the facilitation of the exercises. So far, we've managed to reach 467 post-TB patients into the program. What are some of the key results that we've seen in the program? There's been quite a few, but we're going to just concentrate on 4 key parameters that we measured in the program. So you see Canopy score, which is the measure of functional impairment among patients. The lower the score, the worse the likelihood of the patient's survival. So you will see that at baseline, we had them participants spread across 40% at 90, 8 at 33%, 20% at 70, 8% at 60, and about 0.2 at 50. While if you look at end line, you'll see that 90% were at 100, 10% to 90, and only 1% was on 80, showing a significant improvement in their Canopy score. In terms of chest pain, you'll see that at baseline, 66% said yes to chest pain, and 34% of the 467 said no. Comparatively to the end-line assessment, where you see 9% only saying yes and 91% saying no to chest pain. In terms of cough on exertion, you'll see that at baseline, 53% said no, did not have cough on exertion when we did the assessment, and 47% had cough on exertion. While at end-line, you see that 90% had no cough on exertion, only 10% had cough on exertion. And in terms of dyspnea score, with 0 being no dyspnea, 1% slight dyspnea, 2 moderate dyspnea, 3 being above moderate dyspnea, and 4 extreme dyspnea, you see that at baseline, we had 38% with no dyspnea, 51% with slight dyspnea, 12% with moderate dyspnea, and 0.4 with above moderate dyspnea. Comparatively to end-line assessment, where 99% had no dyspnea and only 1% had slight dyspnea. And the other parameters that also showed really good improvements in the lives of the post-TB patients. So with this experience, we've seen that post-TB associated disabilities start because all these clients, 467, are based off the data that Mona presented of the 1,700 plus. So that assessment included pre, during, and after. So from that and the lung rehabilitation program, we see that these disabilities start pre-TB because most of them are due to delay in diagnostics and then continue during treatment and even post-TB in the lives of the patient. So post-TB associated disabilities, us as a patient organization, feel like is a fitting term to capture the phenomenon. And the following are our recommendation if we were to address post-TB associated disabilities. Screening for TB lung disease during and after treatment would be very good because if we can find a way to address and cure post-TB associated disabilities during treatment and even after assessment, maybe we don't even have to work on curing these after treatment. So assessing them during treatment would be good. But also the lung rehabilitation program has shown that it works and the results are showing that it works and has significant improvements on some of the impairments. So maybe using this approach to treat post-TB lung disease during treatment and post-TB for those that were not able to assess during treatment. Last but not least is to drive this point home to say we need to improve care during treatment and plan for follow-up even after treatment in our approach to curing TB. Thank you so much for listening and being a lovely audience. I'll now hand it over to the moderator to continue.
Thank you very much, Bruce. At least we are seeing examples of what could work at country level and at the community level, and I think that's really, really exciting. The last speaker in our session is going to be Ronnie Zakaria. Ronnie also does not need introduction. And I will ask you, Ronnie, to just go ahead and tell us what you want to tell us.
Okay, thanks, Jeremiah. First, thanks to all my colleagues who've gone before for the excellent presentations and also giving us insight into some of the practical issues of how to address this. I don't have a formal presentation, but I'm just going to say and give you an update on where we are. As you all know, since 2014, the Stop TB Partnerships 4x90 coverage and treatment targets have provided very useful benchmarks against which to assess TB program performance. Since that time, many of us have advocated very strongly and argued that we should add a fourth 90 to ensure that 90% of all people with TB can have a good health-related quality of life. And therefore, this policy document and impetus towards that direction is most welcome. But implicit within that argument for a fourth 90 is the need for TB programs to be able to assess TB patients for TB-related disability, but also comorbidities and risk determinants at the start, during, and at the end of TB treatment so that we can provide a real continuum in care and refer those who need attention for appropriate care within the general health system. The real question is, can this be done from an implementation research perspective within the national TB control programs? So in 5 countries, so in China, and 4 countries in Africa, one of them, of course, Jeremiah is leading in Kenya, Uganda, Zambia, and Zimbabwe, TDR and NTPs, along with the Union and other partners supported by USAID, are supporting the NTPs to set up the patient assessment and referral systems to screen and manage disability. We want to see what the gaps are and how can these be bridged. There are a number of project innovations here. The first is the use of standardized protocols along the board in these 5 countries should generate adequately powered data, which should help shape global policies. We're using, for the first time, real-time data using EpiCollect 5, which is a mobile-based application that health workers can actually directly enter data into, and we can validate. And the third is we want to try as much as possible, as some of our colleagues, I think, have mentioned earlier on, to bring in TB survivors, because, of course, this will increase the load on the TB program, and bringing in TB survivors is maybe one way to address healthcare worker shortages and ensure the sustainability within the NTPs. We are very early in this data. We've started just in June. We've recruited 315 patients as of yesterday. The interim analysis is scheduled for November, December, at which time we're very happy to share this data. Our focus really is, as many of you have mentioned, is let's not wait till the end of TB treatment. Let us start at the first assessment. Let us try to put in the assessment and referral systems during TB treatment and continue after TB treatment, because it may be late for us to wait till the end of TB treatment. Why not act earlier? Thank you, Jeremiah. Let me stop here.
Thank you very much, Ronnie, and thank you all to our four speakers for very excellent talks about this problem. Now we know, Brian did tell us what the size of the problem is. We know the nature of the problems. Those have been highlighted to us by the presentation by Denise. We know that there are interventions that are being trialed, including community-based pulmonary rehab, and we are seeing that there are, in fact, good outcomes that are coming out of those interventions. But yes, we still are not completely there, and that's why research is going to be important to be able to know how best to pick up people who may be developing problems during their treatment for TB. And I like what Brian did say, that we need to think about primary, secondary, and tertiary prevention, because these are all important issues for those who are suffering the problem of TB. So we do have a lot of work to do. We've got a lot of research that needs to be undertaken, right from basic research to understand the pathophysiology of post-TB lung disease or post-TB disability, to how to deliver care to people who have post-TB lung disease and the kind of care that needs to be delivered. So thank you very much for allowing me to moderate in this session. And now I'm going to take you back to Ernesto and the team at WHO to continue with this webinar. Thank you very much.
Thank you very much, Chakaya, for chairing, moderating that panel. Well, it seems to be pretty clear that the burden of TB-associated disability is huge, but it's also clear that there is ongoing progress, not only in terms of building evidence, but also in pioneering some interventions at country level. While the evidence is consolidated in order for WHO to produce guidelines, it seems that it's appropriate at least to outline what would be the policies that should start to be considered country level. I'm very much pleased to invite my colleague, Marcia Calvi, to present the policy brief, the content, which will be informing the next steps in the process to address the needs of the people suffering of TB-associated disabilities. Marcia, floor is yours.
Thank you, Ernesto, and thank you to all the speakers before me. I'm really pleased to tell you that I'm not going to tell you nothing new compared to what have been already said, as the policy brief really successfully captures all the needs and the interventions that the other speakers has already presented, which is a very good news. So to present on this, the policy brief, it's important to, as starting point, again, some refresher on the need and rationale behind the development of this document. As we heard from Denise and colleagues, growing evidence has been produced recently around the fact that those who experience TB have a life expectancies of 4 years shorter than the general population, both in developed and developing countries. And TB survivors are left with some health consequences, even when they are declared cured from TB. Recent literature shows that TB survivors come back to the health systems with other health issues, mainly mental health disorders, respiratory impairments, and neurological impairments. To such global burden, there are also other considerations that are associated. The mortality of TB survivor indicate up to 3 times higher risk of death in the population than general populations, and morbidity associated with TB event can lead to further decline in the health functions, such as with the increased risk of chronic obstructive pulmonary disease or residual post-TB pulmonary impairment, all resulting in poorer treatment outcomes for those experiencing such conditions and clearly affecting badly the quality of life. On a positive side, recent studies shows also good effect of interventions that can be put in place to address such conditions, for example, pulmonary rehabilitation. Having these considerations as background, the WHO policy brief on TB-associated disability presents the social and economic impact experienced by people with TB-associated disabilities, includes a note of people with disability who get TB, and calls for integrated people-centered care. In line with the International Classification of Functioning, Disability and Health, the term TB-associated disability refers to the range of health conditions which, as a result of the illness, the disease, and/or its treatment, in interaction with personal and environmental factors, limit the day-to-day physical, social, and economic functioning. We are talking about walking, self-care, family and community life, and ability to work of people with TB and TB survivors. The most frequently reported TB-associated impairments, as we heard, affect pulmonary, neurological, and mental functions that occur both during and even after the patient is declared cured of TB. The policy brief does not stand in a vacuum, but builds on several global frameworks, conventions, and agreements that are in place and that can and must be leveraged to address the needs of people with TB-associated disabilities. For example, SDG 3, the anti-TB strategy, Rehabilitation 2030, Defeating Meningitis, the Global Roadmap, the Intersectoral Global Action Plan on Epilepsy and Other Neurological Disorders, and the United Nations Convention on Rights of Persons with Disabilities. All these documents relate mainly to health and social sectors, with the most relevant one being those for TB, rehabilitation, UHC, social protection, and mental health. Moreover, the policy brief aims to inform and promote, strengthen collaborative actions between national TB programs and other disease programs and health system functions to deliver people-centered care to individuals that experienced or experiences TB-associated impairments during and after the TB treatment. Although we will have a panel after my presentation talking about the investment and the importance of investing in TB-associated disability, I would like to mention quickly the benefits that the policy brief shows of comprehensive, integrated, people-centered care for people with TB-associated disability that can be summarized under three main areas. First, the improved health functioning and TB treatment outcome of persons with TB-associated disabilities, as rehabilitation services are shown to optimize people functioning, improving their day-to-day activities and community participation. Second, the reduced health system cost, as rehabilitation services can contribute to reduce overall health expenditure by reducing complications and conditions that may require additional health and social protection services. And third, improve the well-being the societal well-being. So the policy brief shows how quality TB care may improve the impact and burden of TB-associated disability. And when we talk about quality TB care, we talk about early TB detection, effective social protection measures, early detection and proper management of TB comorbidities, and immediate enrollment on effective treatment. And when we talk about the impact and burden of TB-associated disability, we talk also about mortality of people with TB and TB survivors, health-related quality of life, the health system overall cost, and the performances of the national TB programs. The policy brief also presents some most critical considerations to address TB-associated disabilities, and in doing so, it presents 7 key approaches that include, first, establishing a comprehensive, integrated, people-centered TB care that addresses associated impairments and disabilities. And here we include early identification and screening for impairments, subsequent rehabilitation needs, including follow-up and case management of at-risk populations during and after the TB treatment, and the effective and timely referral mechanism for rehabilitation and mental health services. Secondly, ensuring effective planning across health systems, ensuring that rehabilitation services are part of the national health planning and have adequate funding, strengthening the rehabilitation workforce and quality of rehabilitation services, as well as building rehabilitation competencies among health workers engaged in the delivery of the TB care. Third, addressing stigma and discrimination towards people with TB and related disabilities, acknowledging the importance of raising awareness in the communities and also ensuring that information is available. Improving collaboration with social support and social protection services, including engagement with people with TB-associated disabilities who may benefit from a range of services that extend beyond healthcare, such as support to social inclusion, legal protection, access to education, and social protection benefits. Expanding social awareness of the needs of people with TB-associated disabilities, including drawing attention to the unmet health and social needs of people with TB-associated disabilities, including through the voices of TB survivors, people and families affected by TB-associated disability and civil society, and engaging with people with TB-associated disability in the decision-making process. 6, promoting multisectoral collaboration, reinforcing multisectoral approaches to tackle TB-associated disability through mechanisms such as the multisectoral accountability framework for TB, and promoting multisectoral and multi-stakeholder collaboration in the design, planning, and implementation of services for people affected by TB. And last but not least, generating information and evidence, including collecting adequate data and information to enhance the understanding of the needs of people with TB-associated disability and accordingly to support effective decision-making. The policy brief is a starting point to engage in this area, and it will serve as a baseline document for future development, as Ernesto said, of WHO normative products. And with that, I would like to acknowledge the work of my colleagues and partners and the civil society task force that contributed in the development of the document. Thank you.
Thank you very much, Marcia, for presenting the content of the policy brief that will be soon available in our website and will be distributed widely. And thank you very much as well to all of you who after 90 minutes have remained with us. I mean, we have seen that the participation has ranged between 90 to 100 people online, which confirms the interest and the relevance of this topic that has been a bit overdue. Now let's move to the last phase, the last section of this webinar, which is, okay, is there going to be funding to address this? I would like to invite my colleague, Askar Jadilbayev from the WHO European Regional Office to moderate the next panel, which will have 3 speakers who will be addressing the question, why to invest in addressing TB-associated disability. We will have Eliud Wandalo, who is the Director of the Department in TB in the Global Fund. He is from Tanzania and who has for many years been a leading force in the response to tuberculosis from his position in the Global Fund. Then we are going to have Dr. Manuela Retanz from the Ministry of Education and Research in Germany, which has been, although her background is in basic science, she has been leading an important collection of projects contributing to build research capacity and is the main donor of a leading project that is collecting evidence to inform future policies on how to address TB-associated disability, particularly pulmonary comorbidities. And finally, we have Suvanand Sahu from the Stop TB Partnership. Askar, are you with us? Over to you.
Yes, thank you very much, dear Ernesto, colleagues. and it is my pleasure to chair this final part of the webinar. And with no further ado, I would like to ask our participants, the first, Dr. Elliot Vandwala from the Global Fund, to give an intervention on and answer the question of why to invest in the field of TB-associated impairment and disability during the and post-treatment is important. Thank you, Elliot. The floor is yours.
Thank you, Oscar, and good afternoon, good evening, colleagues. We are very happy, Global Fund, to be associated with this webinar. It's a very critical webinar. We are just coming from New York, still with jet lag, but I think it was very successful, as highlighted by Teresa. And also, I had some sobering statistics as well when I was in New York. That TB has killed 1 billion people in the last 2 centuries. So that is very sobering. And probably TB would be the biggest killer of all causes of death, I think, if it's 2 billion. But also in that 2 billion death, we have a lot of disability, which I'm sure will be surpassing any form of disability. So the case for investing in TB disability is very clear. I don't want to repeat the statistics which have been highlighted in this webinar, but from Global Fund perspective, we don't look at it as a pure TB issue. We look at it really as a human rights issue. And for our approach in our current strategy is a patient-centered approach. The current way we are treating TB, we are actually treating mycobacteria. We are not following a patient. And if you really want to treat a patient, it should be a total sort of management of the patient. Not only, you are satisfied when the patient doesn't have mycobacteria, but you are satisfied when the patient goes back to their normal routine lives. And we believe that having an approach which is going beyond the mycobacteria is the right approach, but also it's because for us, the biggest issue is really to make sure that the vulnerable, the people who don't have voice, they are being covered. So this is really according to our strategy. The other reason is that we see management of disability for TB and beyond. It's really beyond a TB issue. And I think we really need to involve multi-sectorial, we need to involve other sector of the health when it comes to this. And this is in line with our strategy, where we are looking at the moment, how do we support health system in a way which can support TB, HIV, malaria, but also support other diseases as well. So we are looking at this as a way to contribute to that. Now, from Global Fund perspective, we have put this as part of the area which is eligible to be funded in the current funding request in the GCC7. Unfortunately, we didn't see a lot of countries putting TB disability in their funding request. I suspect it's because of the awareness among stakeholders, TB programs and other stakeholders. Probably we saw 1 or 2 countries which have mentioned actually in passing, not really having concrete intervention in the current funding cycle. So for countries which have not yet submitted their funding request, let's be assured that this is part of the eligible component. You can include in your funding request and it will be reviewed and the Global Fund will be happy to support. So I think we need to have a lot of advocacy so that this one should be included. I've seen in this webinar, we have researchers, we have policymakers, we have implementer, and it's good to attack it from different angles, but we shouldn't wait to have concrete data because we know people are affected. Nandita was there. She's a living testimony that people are affected, and we should start implementing, and we'll be learning as we implement. So Global Fund is so much supportive of this, and we are looking, supporting this beyond TB funding. And this is a message to NTP manager, to other stakeholders. Don't stick to TB funding. This can be funded by so many streams of funding. there's pandemic funding now. There are so many streams of funding because this is beyond TB. So we should look broader than just looking money with the label of TB. And that's what we are also looking here at the Global Fund to see whether we can tap other funding sources which could support this. Lastly, Global Fund is working with a number of countries now to help them with a small project. And this was after the Arusha Declaration. We had a meeting with a number of countries in Africa. This was one of the areas where there was a lot of interest. And now we are discussing with a number of countries, mainly in Africa, to be able to support small-scale implementation under the program, under routine program. And we hope that we'll be able to secure that funding, and this will add to the knowledge to the WHO and other stakeholders to include in the NSP. I'll stop there. Thanks, everyone.
Thank you very much, Eliud, and for highlighting the perspectives from the Global Fund. And indeed, it's very important that the Global Fund strategy there is a recognition of this important issue to be highlighted, and there are many funding opportunities supported by your organization for the countries to reflecting the current proposals, and that if this issue will be addressed. What is also important is that people-centeredness is going throughout the strategy of the Global Fund, and it will be highlighted by the countries. So with no further ado, I would like to give the floor to Manuela Rechtans from the German Ministry of Education and Research. Floor is yours, Manuela. Thank you.
First of all, thank you so much for having me, and also thank you to the webinar organizers for including the civil society along with the researchers in this webinar. It is always important to hear about personal experiences and about the realities patients face, because this is really what should remind us of where our focus has to be. As a representative of the German Federal Ministry of Education and Research, and I'm not directly in the ministry, I'm at the DLRPT, the project management agency of the German Aerospace Center, and we manage thousands of projects for the ministry, but I'm not there directly. I can inform you on the ministry's view concerning tuberculosis, which of course focuses on funding research implementation and on research uptake. TB and other poverty-related as well as neglected tropical diseases are important for Germany, which is why the government invests so much on or in WHO, actually, including its support for the Tuberculosis Action Plan. Also, the Global Fund that we just learned about. Also, EDCTP with a number of TB projects, and the PDP's TB Alliance, and IAVI, Unite for TB, and TB Sequel as part of the RISA research, the RISA funding measure that we heard about, for example, by Brian Elwood, and also other organizations and initiatives, national and international. So what may be important for this audience here is that when TB Sequel submitted its first proposal for the first funding phase that ended at the beginning of this year to the BMBF about the need to invest in post-TB lung disease research, and that was about 10 years ago, it really strengthened the awareness that addressing TB does not simply equal fighting infection, which we have heard so often today already, but that there can be severe long-term impact and disabilities. And this, I think, was often, especially by ministries, not common knowledge. As we've heard from civil society also, that there are people not knowing about the loss of hearing and these things. And this is why webinars such as this are so important, to be reminded what is all included, not just looking at what you have to deal with daily, but understanding what patients actually have to face. So consequently, in the initiatives I have mentioned that the BMBF supports, nearly everything is targeted from better diagnostics via treatments to vaccines and post-TB lung disease, including needed trials. And coming back to the question of why we should invest, as we have heard before, this is really a no-brainer in the end. We need to address TB holistically. And maybe a holistic approach to being healed and healthy here does involve a few more steps and topics, as we've learned, than with other diseases. And with the TB sequel, as with the other research projects, we want to pave the way for research uptake. It is a very important part of this funding measure. TB sequel partners, along with the others, as a mandatory work package, have long started to talk to government representatives in their partner countries to make sure that their research results will be brought to policy and practice so that the people can benefit, which is what research in the end should all be about. And there is no definite program, if you will, a specific plan of the BMBF to fund TB-associated disabilities, but it has this approach that has become more and more important over the last decade or two, that diseases, conditions should be addressed holistically. So TB sequel with its approach is part of this, which we hope will be very successful, as it already has been in funding phase 1. And TB sequel, which is also interesting, is just one of 2 of the networks that actually made it into the funding phase 2, which has just started. So BMBF also advocates for access, which is important. And I think, I'm so sorry I haven't prepared slides, I didn't have the time, but I think I've said everything that is important, and I think I'll stop here. Thank you so much again for having me. If you have any questions, please let me know.
Thank you very much, Manuela. And indeed, the invaluable support that is coming from the government of Germany into investment, into supporting the tuberculosis activities, not only our WHO European region, but globally, is very important, especially in supporting the research and recognizing as the post-tuberculosis Lyme disease research as an important aspect. With no further ado, I would like to give a floor to Dr. Suvanant Sahu from the Stop TB Partnership for the last intervention in this panel. Sahu, floor is yours.
Thank you, Oscar. First of all, congratulations and thanks to WHO for highlighting this issue with this policy brief, but also what we heard today is some further work that WHO is doing for ultimately a kind of normative guidance on this. Last week, some of us were in New York for UNHLM and did see a lot of visibility about TB. As Teresa said in the political declaration, there are mentions of disability, and I think it is up to us now to go forward and see what can be made concrete on this in terms of action. So I would mention a few things in my discussion here. First, I agree with all speakers that if we focus our attention on people, then automatically this gets included. Otherwise, we will continue to talk about the bacteria, the diagnostic, the medicine. But as soon as we focus the attention on people, then it gets covered, and that should be the approach in dealing with it. I want to highlight that to get to investment, that's the kind of thing we are discussing here. The first step is awareness. And I would appeal to all partners, including WHO, to think about some clear messaging on this issue. We often say TB can be cured. We say TB can be prevented, diagnosed, treated, cured. But we often fail to mention that not everything can be cured. The stigma, the discrimination that comes with it, some of the impairment of respiratory function and all that remains. It is not cured. So I think the messaging is important. We also need to be clear on the messaging on people may have disability and get TB, and people may have TB and as a result of that develop some disability due to the bacteria, due to the process in the human body, or also due to the medicines and whatever happens in the care. But I would also request that let's think about a holistic approach where we include human rights, stigma, mental health, respiratory disability, and disabilities due to extrapulmonary TB. As somebody mentioned, meningitis, TB of the bone, that creates a different kind of disability. Plus also including this pre-existing disability. And maybe it'll be good to think about, because of the COVID experience, I was thinking about long COVID. Can we have a long TB where everything can be included, not just lung, but also extrapulmonary, everything, all dimension, and call it something simple that people can understand and connect to, like long TB. The second point I wanted to make is in terms of action, because anything that requires money, people will ask about what is action. So I think very aptly, some people mentioned about preventing disability, and I think this should be the focus of early diagnosis, safe treatment, but also thinking about how we can prevent TB, for example, in contacts that we don't get into this situation. But there are two, I think, approaches where we should also think about. Some things can be done by TB program, but some things needs to be done by the general health system, and how to connect the two, and how to make also the health system understand and connect the TB program with the health system. The third thing I would also focus our attention is funding. As Eliud mentioned, the countries are not proposing even in their proposals. So how to make this area a priority one, because we know that countries struggle because of the lack of funding. The UNHLM funding targets are 5 times higher than what is currently available, 4 to 5 times higher, right? So in that setting, if you don't have funding for drugs and diagnostics, how do you include this? So I think we need to think about how do we set the priority of this aspect. And as long as we just focus on the statistics, the numbers of people, either TB incidents or mortality, and call it impact, I think this aspect of people and the quality of life will not come through. So some articulation is required on how to set this as a priority. And as Eliud said, the label of money is very important. It may not be labeled as TB. It may be labeled as mental health, non-communicable disease. It's fine as long as we are able to flag that there is a need for TB in those labels of money. And finally, as we know, what doesn't get measured will not be done. So it will be good to think about how we can include this in the measurements that we do. From Stop TB, we have been working with partners on the CRG assessment. We may think about doing something to include some aspect of this will be included in the CRG assessments, not all, but maybe some measurements will be required. Are we making progress or not? So I would stop there. Again, thanks for highlighting this issue. Thank you.
Thank you very much, dear Sahu, for summarizing the needs to address this important issue, this issue from this Stop TB partnership perspective. But basically, as a summary of this panel, I would like to say that indeed there is no question of why we should invest in tuberculosis and in everything that is affected by tuberculosis, including the post-tuberculosis disabilities and impairments. With this, I would like to say that there is a potential support from partners, not potential, but actual support from the donor organizations to address these issues, and countries are encouraged to reflect that in their current proposals or to express interest to any other funding streams. Because indeed, this issue should be addressed, and we should ensure that nothing is leading to disability after COVID, after tuberculosis. With this, I would like to give floor back to Ernesto, and we are done with this panel. Thank you.
Thank you very much, Oscar, and thank you very much for the speakers of this panel, to Eliud, Manuela, and Subhanand. Well, it's an immense work, and WHO will be taking now further steps, particularly in convening an expert consultation to develop an operational research protocol that can help us to inform a practice at country level. Thank you also as well for those who have been staying with us until this late. Now we have 80 participants, and let me invite Teresa to share her closing remarks with us. Thank you.
Thank you very much, Ernesto. Dear colleagues, it was a true pleasure to have this webinar, as I've told at the beginning, and our expectations became real. It was a very fruitful discussion. I would like to thank all the speakers, all the moderators of the session, and we received a lot of important messages and proposals that will be definitely taken into consideration. And it looks like we're reopening a well-known, not new chapter, and the leading agency, the fight against tuberculosis and on the global health arena. I would like to confirm that we will try properly address all the requests and first of all needs of people suffering from tuberculosis. It's millennium-old disease and the progress is not sufficient, and that's why we are here in WHO across all three levels, constantly thinking and trying to address properly and to fill the gaps, as colleagues told. That's why a few years ago, for example, we've revamped focus on the whole prevention agenda, because traditionally we've been focused on diagnosis, treatment. Of course, it's reasonable, it's clear, but other aspects should not be neglected. That's why exactly now we are trying to fill the gaps related to the policies, guidelines to address TB associated disability, post-TB disease, rehabilitation, and all the essential aspects that are not that common, unfortunately, in our routine care of people with tuberculosis. It's time. And during this high-level week in New York, of course, many interesting conversations at the high level happened, and probably we'll have another opportunity to share and in detail with you all these findings from this communication. But definitely one of them that we should shift from our routine traditional approach to more comprehensive approach, adequately address tuberculosis. We should more actively share this knowledge about tuberculosis, not only as a preventable and curable disease, but that should be prevented, treated, cured. And the point that people reached have negative tests should not mean that this is end of the story. To be sure, the disease will not come back again, and to be sure that we are eliminating disease, eliminating reservoir, and first of all, we are aimed to improve quality of life people even after TB and prevent development or returning back of the disease. Much more should be done. This is the beginning of this new step, and we will be happy to work closely with all of you to benefit from your knowledge and experience. And as colleagues told, this policy brief will be followed soon by the comprehensive guidelines to address these important aspects of care. With your permission, I would like to thank my team. They're all here, key people drivers, Ernesto, Marce, Farai, Mafuna, all team, Sebastian providing technical support for this meeting. Let's stay in touch and to be continued.
Thank you.
Thank you.